Good afternoon, everyone, and welcome to our BHA Provider Rule Town Hall for chapters 8, 9, and 10. So that is our residential services chapter, our crisis and emergency services chapter, and our emergency and involuntary substance use commitment chapter. We will go ahead and get started. First, want to let you all know that we have 2 American Sign Language interpreters with us today that will alternate throughout the session. If you want to see that interpretation, you can pin these boxes to your main screen. Those are ASL interpreter Karina and Sean. So you'll select Gallery View from the upper right corner of your screen, click on the interpreter screen and select the More button or the 3 dots. You will select Pin Video and repeat this process for the second ASL interpreter. And a big thank you to Karina and Sean for their assistance today. We start all of our meetings by reviewing our behavioral health administration values. Those are truth, equity, collaboration, community-informed practice, and generational impact. So these are things that we keep in mind going through this rule drafting process. And today, looking forward to collaborate with you all and allow these rules to be informed by community-informed practice in particular. Housekeeping. So we have 2 hours booked today. I will say these are a little more dense and content heavy chapters. So we may make some adjustments as we go as far as when we stop for questions. We may at a certain point, if we're running low on time, respond to questions in the chat, but maybe not necessarily live aloud. And if we're really running tight on time, we may have to take some questions offline. So we are going to do our best to get through everything and make sure we have time to address all questions. As you can see, this video is being recorded and it will be posted on the BHA's YouTube channel. That YouTube channel link can be found on the BHA website and in the chat. BHA staff will have access to chat and transcripts to ensure those comments are captured. And we encourage you to share whatever you're comfortable with in this venue. Those could be questions, those could be feedback or recommendations for the rules. And you can use that chat function. You can also raise your virtual hand. We ask that if you would like to come off mute, just because we have a number of participants here today, that you are using that hand raise function so that we can call on you to unmute. We also have our email inbox, the CDHS BHA rule feedback that we monitor daily, a Google form survey where you can submit rule feedback or questions as well. So if we are running low on time today, please feel free to reach out through email or the Google form if we do not get to that question today. So today's town hall, I'd like to get us started with an introduction of our BHA staff on the call today. My name is Victoria Lasky. My pronouns are she, her, and I am the Safety Net Associate Director within Quality and Standards at the Behavioral Health Administration. I will call on members of my team and we will introduce ourselves today. And I will start with Mariana.
Thank you, Victoria. Good afternoon, everyone. My name is Mariana Sears. My pronouns are she, her, and I'm one of the Safety Net licensing managers that will be talking quite a bit today. I'll be presenting on residential services, including withdrawal management at a level 3. I will go ahead and turn it over to Erica.
Hello, everyone. Erica Gannett, she, her pronouns, also a Safety Net licensing manager. And I will be talking today about mental health transitional living homes, which are a level of care within the residential continuum. And I will pass it over to Olivia.
Hi, everyone. Thanks for being here. Olivia Zern. I use she, her pronouns. And I'm also a Safety Net licensing manager under Victoria, and I will be presenting on chapters 9 and 10 today. I think that's everyone. So we'll go back to Victoria.
One more, not a presenter today, but we have our special guest and fearless leader here. Tom, if you could introduce yourself.
Olivia, I'll make a note that you forgot about me.
Aren't on my
No,
screen, to be fair. I didn't know you're here yet.
that was mean of me to do to you in front of everyone, but I did want to keep it as light as possible. So thanks for having me here today. Tom Miller, he, him, his pronouns. I'm the division director for the Quality and Standards Division. I'm so proud to be a part of this group. And please, they bring me along so I can see more of their fantastic work. Thank you for joining us, everybody. Now back to you.
Great. Thank you very much. And thank you all who are joining us this afternoon. As I mentioned, we will be focused on providing information about chapters 8, 9, and 10 of our rule volume. That is our residential services, which does include level 3 withdrawal management. A note there, if you've been hanging out with us for a while, you may recall that withdrawal management used to be in its own chapter. And that has now been integrated into the residential services chapter to make that build in a way that made a little more sense across the continuum. And that really was driven by stakeholder feedback. So if you were part of providing that feedback, we appreciate that. Chapter 9 is our emergency and crisis behavioral health services chapter with a number of sub-endorsements under that. And then our chapter 10, emergency and involuntary commitments, or EC and IC. So just for your information, this meeting will be more presentation and content heavy than some of our other stakeholder events. We do have a number of different styles of events. A good number of those are more of a listening session or discussion based. Today is going to be more of that presentation and content. Again, we will have time for questions and feedback, but want to make sure we're setting that expectation of this is going to be a little more presentation heavy than some of our other events. You can see those remaining events. We've got another about 2 weeks left for receiving comment on the rules. That will close at midnight on June 23rd. And we still have a number of events in these last 2 weeks, including a couple of in-person events in Grand Junction and Pueblo. So please check out that calendar to see if there are any others you may be interested in joining us for. We also are excited to announce we have a new way to stay informed. This is the Quality and Standards newsletter, where we will be sending out updates periodically regarding our rule promulgation, as well as any other relevant updates to things like ladders or just anything licensing, designation, quality and standards within the BHA. We've got our first newsletter almost ready to send out. So if you have already signed up, please know that you can expect that shortly. And if you are not signed up, but you are interested, you can sign up given the form, which I believe was just dropped in the chat. All right, without any further ado, we will dive right in and I will hand it over to Mariana. I believe she is starting with chapter 8.
All right, thank you, Victoria, and hello again, everyone. So absolutely right. I'm going to get us started with chapter 8, and Erica and I will be tag teaming a little bit. Chapter 8 is our behavioral health residential services, including level 3 withdrawal management. So this particular chapter is going to be applicable to all agencies providing residential services to individuals living with substance use, mental health, or co-occurring disorders. And as Victoria mentioned, this now includes level 3 withdrawal management. So if there are services being provided to individuals withdrawing from substances where they are staying at the facility, this includes 3.2 withdrawal management as well as 3.7. Next slide. I should have said please. Sorry about that. Next slide, please. So as always with these chapters, we want to start with our person-centered summary. This is meant to be written to the individual who's receiving services to better understand what the service is and why it is beneficial for them. So residential facilities provide our recovery serviced environment, including trained personnel on site for support all day, every day. Here you will learn and practice recovery skills, participate in treatment to help maintain your recovery. You may seek out residential treatment on your own or be ordered to the court to complete a residential program. This may include overnight withdrawal management services, where trained personnel provide 24-hour monitoring and oversight to make sure that you're safely withdrawing from a substance that is recently used. Mental health transitional living homes are a new residential setting that is designed to support you when you're no longer needing a hospital level of care, but need help with your daily life due to your mental health needs. In this transitional living home, you're supported with your daily personal care, taking of medication, developing life skills to be able to live independently in the future, and getting the ongoing treatment that you may need in a non-hospital setting. So whatever brings you into residential services, the end goal is to make you feel stable, support your recovery, and transition successfully into independent living. Next slide, please, or into community. So the majority of what I'm going to present, it's really kind of heavy as far as familiarizing with the new structure of Chapter 8. I think that's where the most utility is probably found, because this is one of the chapters that looks significantly different. As Victoria mentioned, this used to be divided up into 2 chapters. And the chapter numbers had moved around a little bit, but really what we have now is a chapter that builds in alignment with the continuum of care. So I'm going to start pretty heavily on the first 4 parts of Chapter 8, because that is, if you fully understand how to navigate that part of the chapter, the rest of it starts to click into place. And again, this was primarily done based off of stakeholder feedback that pointed out that this was not flowing as well as it needed to. So really do appreciate that you helped us get it to the point where it is now, and hope that we can just keep making it better with continued feedback. So part 8.1 is applicable to all residential and withdrawal management facilities. It is the authority and applicability section. Part 8.2 is our definitions, and that will be applicable to all facilities as well. Part 8.3 is our behavioral health residential and level 3 withdrawal management services standards. So this is, these are services that are applicable to all as well. And then part 8.4 is one where it's starting to get a little bit different. This is where these particular standards are applicable only to behavioral health residential services. So level 3 withdrawal management programs would be not subject to this particular part. One thing I want to highlight, what we've talked about on other town halls as well, is there was a lot of work to make sure there is a standard flow to these parts so that it's easier to navigate the chapters and figure out where you need to go to get the information you need. So you will see there's a repeated pattern in the rules when you look at that, as well as the presentation today of 8 point whatever number we're looking at. Point 1 is going to cover service delivery and setting. 8 point whatever number we're looking at, and point 2 is going to cover personnel requirements. 8 point that number, point 3 is covering service provisions, and then 8 point whatever number that is, point 4 is documentation and timeliness. So we'll make sure to highlight if there are ones that are applicable across sections. We'll make sure you understand how that works. Next slide, please. Okay, so part 8.1, if you've looked at this chapter yet, you might have seen that this is a pretty hefty authority and applicability section. And I think this was done intentionally because this part 8.1 is meant to be flexible, allow for change, and it is really the primary foundation for understanding how to utilize this particular chapter, knowing that it does build a little bit differently. So it builds as the continuum of care naturally builds. And we did find a way to insert the mental health transitional living homes where those would naturally build within the continuum of care as well. You will see in this authority and applicability section a reference back to the treatment type, which is defined in Chapter 1, that the agency wishes to serve. They may choose substance use disorder, mental health disorder, or co-occurring. So again, trying to pull both options together. And then, as mentioned in that previous slide, ones that are applicable to all residential facilities, Part 8 through Part 8.4. And then just to emphasize, Part 8.1 through 8.3 are applicable to level 3 withdrawal management. That removes that 8.4 requirement that is more tailored to residential. And then in addition to whatever residential or withdrawal management that the agency is providing, we would then navigate to the relevant sub-endorsement for the service that they're going to provide for those particular standards. Next slide. Okay, so the next couple slides are going to show you how we have essentially categorized and structured our current state of levels of care. They're divided down into 3 categories. The first one is clinically monitored services, and we do have that definition as we go through the presentation and start looking at clinically monitored levels of care. We'll talk about what that means. The only service that currently lives under clinically monitored as of today are level 1 mental health transitional living homes, which are part 8.5. The majority of our services in this chapter live under the clinically managed realm. And again, they build as they would in the continuum. That is ASAM 3.1 type services, level 3.2 withdrawal management services, followed by 3.3 type services, level 2 mental health transitional living homes, and then ASAM 3.5 type services. Next slide, please. And the third category that we have current state is medically monitored services. And my apologies, the Hulk is beating Captain America over here. And that includes ASAM 3.7 type services, followed by a level 3.7 withdrawal management services as part 8.12. I included medically managed as kind of a placeholder. That is not something that we currently license, but the nice thing about this structure is it leaves a placeholder for that. So if future state there is room for a medically managed category, or as that builds into future ASAM revisions, there would be room for it automatically built into the framework. Next slide, please. Part 8.2 is our definition section. And again, this is applicable to all residential services and withdrawal management. I've included a little snippet of a handful of definitions that you'll see here from both chapter 1 and chapter 8, but this is certainly not an exhaustive list. The one that I will highlight here, just to make sure there's some clarity around it, I understand that the level 3 withdrawal management might cause a little bit of confusion. Is that a brand new level of care? What does that look like? If you look at that definition, really what it is a way to refer to both ASAM 3.2 withdrawal management and ASAM 3.7 withdrawal management at the same time, if they have a similar standard, without having to write out both of their full titles over and over again. So it is not a new level of care. It is encompassing both 3.2 and 3.7. Next slide, please. Okay, so service delivery and setting, part 8.3.1. Again, this is applicable to all services in this chapter, residential and level 3 withdrawal management. We added some enhanced guidance and factors to consider in services, particularly around the living space assignment for individuals and the overall milieu. The goal of adding in these standards is to promote safety and avoid abuse, including psychological harm. Person-centered and trauma-informed services. And so instead of just having a couple factors to consider, as we have in our current rule, we have added in a handful of other ones that are absolutely relevant for person-centered services. We now ask the agency to consider age, the individual's gender identity, cultural needs that are identified during the assessment process, the individual's sex, their ability to interact safely with others, and the individual's request. Next slide, please. Continuing with that service delivery and setting applicable to everyone, there is more guidance around the management of the physical space. It may now include, but is not limited to, physical barriers such as doors, walls, personnel oversight of activities, workstations that might divide up living space assignments, or video, other monitored oversight, and other practical arrangements that support the safe management of the milieu. Next slide, please. Personnel requirements. Thank you, Heather. Part 8.3.2. So agencies that are providing behavioral health, residential, and level 3 withdrawal management services have on-site personnel 24 hours a day, 7 days a week. We've added in some standards. Let me just 1 second. That is super distracting. My apologies. Okay, we'll see if that request worked. No guarantees. So if you look at the rules, we have this requirement can be fulfilled with a combination of personnel, and it's up to the agency to decide how best to manage that milieu. We have treatment personnel, and that is defined, and we'll go through that here in a second. We've added a category of milieu management personnel, which includes the new group living workers definition, or the site can be managed by combination of both treatment qualified and milieu management personnel. So as you can see, treatment personnel has a little asterisk on it here. And we'll see as we move forward and look at the levels of care, that treatment personnel, as we have it in the rules, does not include clinically monitored services. So the level 1 mental health transitional living home. And that was done intentionally because we wanted to make sure that that's a different type of service that did not require those treatment personnel to be on staff 24 hours a day. So at the site. So that is how we wanted to make sure that we had that nuance captured at this current moment. And Erica can speak a little bit more to that when she gets to her part. So personnel requirements that are set up are specific to each physical location where the services are providing, including the on-call personnel that may assist, and qualifications and credentialing of the personnel providing treatment are intended to reflect the population served. And that will be noted in the relevant sub-endorsements as well. Next slide, please. Okay, so as just mentioned on the prior slide, what we're looking at here is the definition of treatment personnel and how we have that written out in our rule. This is applicable to clinically managed and medically monitored services. Behavioral health treatment personnel include authorized practitioners, licensees, candidates, counselors in training, and interns. And again, this particular list was updated after a lot of stakeholder feedback to really make sure that it's reflective of who can and should provide those services. So thank you for your help there. If the agency is providing substance use treatment disorder, co-occurring, or withdrawal management services, they may also include certified addiction specialists or certified addiction technicians as part of their treatment personnel definition. Next slide. And then for milieu management personnel, we have this written into rule that in addition to the treatment personnel that we just looked at, the program may utilize peer support professionals. If they utilize peer support professionals, that will be done in accordance with Chapter 6 recovery support standards, or group living workers. As mentioned, this is a new category that is being proposed, and this particular professional has to be assigned duties that are within their training and scope, need to be assigned to a clinical director or licensee for oversight to make sure that they're managing the milieu in the best possible way. And in the case that this group living worker or this residential program is in a correctional facility, the personnel that are assigned, if they're group living workers, must be responsive and accountable to the clinical director or another assigned clinical supervisor to ensure that the culture of the program is supported. Next slide, please. Part 8.3.3 goes into service provisions that are applicable to both residential and level 3 withdrawal management. This list probably looks familiar. Most of this is already in current rule, and I won't walk through every single one of these, but the way we have it written is the agency needs to provide a range of treatment approaches to meet the individual's needs, including but not limited to everything that you see there, and ensure that care coordination can occur if the agency does not provide a service that the individual is in need of. Next slide, please. And documentation and timeliness. This one in 8.3.4 really does just point you back to the relevant sub-endorsement for those standards. So you will see it looks a little bit different than our first proposed volume because it does have some repeated standards, and you'll see that through the presentation. But It does allow for future state of more tailored standards for each level of care, which I think will be a really helpful aspect of this restructure. And again, that was aligned with stakeholder feedback to make sure that we really have the flexibility to tailor this. Next slide, please. So then, whoops, that should say part 8.4. I will fix that before that gets sent out. Residential services. So this is applicable to residential services, but this is the one part in that base structure that is not applicable to withdrawal management programs. You'll see that the rules that we're proposing really emphasize meeting of the individual's identified behavioral health needs, either through the agency or through a referral and active care coordination process. The residential services require personnel to receive training and demonstrate competency in house rules, which is a new standard that we're putting in, as well as psychiatric advance directives. If an individual does not have a psychiatric advance directive, but they are interested and it's clinically appropriate, there's also a standard that the personnel will assist with that process completion. And one of the things that we were excited to put in there was opening up training options so that there's more ability to receive the training that's required to provide these services, more in line with the way the health department allows training for some of their facilities. So options include formal instruction, self-study courses, and on-the-job training. Next slide, please. Okay, there we go. So part 8.4.3, residential general provisions, again, not applicable to level 3 withdrawal management. We've added in safety checks. Personnel must conduct and document safety checks at a rate that is sufficient for the individuals served between the hours of 10 p.m. and 6 a.m. We didn't want to be too prescriptive on this one by identifying what that frequency needs to look like, because it really should be tailored to the population that's being served, and it might fluctuate based on the acuity of individuals that are in, or the cohort of individuals that are being served. So we definitely want to encourage the provider to make that decision and to be able to document and justify how frequently they need to be done to maintain safety. There is a standard written in around telephone services that needs to be available on site and include video phone for hearing or speech impaired individuals that are served in the facility. That was also added based off of stakeholder feedback, so thank you for that. And then there is a portion that speaks to court-ordered residential referrals. This is one of the situations where the provider may receive a referral from the legal system that requires a certain length of stay that differs from clinical necessity. And so the standard that we've written in here is that the agency is to address those differences identified directly with the with the supervising entity and document the results of that discussion in the individual's record. This is meant to start to figure out a way to align legal requirements, clinical necessity, all of that, getting more information to empower the provider to provide the services that are required for the individual while still meeting their court-ordered requirements. Next slide. The other applicable to all residential facilities is the inclusion of house rules. This looks a little bit different than the first time we stakeholdered it based off of feedback that we received. This expectation involves the development of house rules that are written, placed in a location where they're available to individuals served and visitors. It must include actions that can be taken if rules are knowingly violated by the individual served. And we do have a list of minimum expectations that need to be addressed, but there can be more if there's something else that's needed. We do have a new standard that was written in to make sure that service animals that meet ADA standards are not considered pets, and they must not take these rules, or these the house rules that are developed must not take the place of or conflict with BHA rules, must not delay, discourage, or prevent an individual's ability to exercise their rights, and need to be revisited at least annually to allow for collaboration and feedback from individuals served. Next slide. Okay, so we are finally at clinically monitored services, which means you can get a break from me droning on and we can get it over to Erica. So I will go ahead and hand it over to Erica here.
Thanks, Mariana. Yeah, so as Mariana shared, as she kind of laid out this new residential continuum, clinically monitored services at this point include our level 1 mental health transitional living homes. And so I'm going to go over those rules here. But just to start, clinically monitored services, the way that that has been defined is it clinically monitored means that behavioral health services are accessed in the community and not provided directly on site by the agency. The agency is responsible for monitoring of the individual's engagement in services and coordinating care as needed. And thank you. I'll take the next slide, please. So this service delivery and setting of level 1 mental health transitional living homes mean a community-based residential agency providing residential services to support there's a typo, to support individuals who require ongoing support with daily living due to the behavioral health diagnosis, but whose needs do not rise to the level of hospitalization. So all of the level 1 homes will comply with the requirements that Mariana was just going over. So parts 8.1 to 8.4, with the exception of that one place that we call out the difference in personnel expectations at this clinically monitored level of care. And I will take the next slide. I caught a typo on this right before this, and it's not showing up here because we were already sharing, so I apologize. But staffing ratios should be determined based on the needs of the individuals when we're talking about personnel. And then personnel may not provide support with ADLs that exceed personal care tasks, unless appropriate licensed and or trained. So those personal care tasks are specifically defined within Chapter 1, and those are typical tasks that do not involve any nursing or specialized techniques. That is what is allowable for personnel without additional license and training. And then nursing delegation procedures need to be followed anytime there are nursing tasks that are being developed, and that should be done in compliance with the Nurse Practice Act, which is written into the rules here. The reason for including these additional rules is that this level of care is designed to support individuals that may have additional needs in terms of their support needs around activities of daily living and things like that. Personnel requirements for providing non-medical transportation are also included in this part because this level of service is required to provide that to individuals served. And then when using contracted personnel to deliver services, the same personnel rules apply. So that is also clarified. In terms of the services that are provided in this setting, these services include assistance with activities of daily living, including medication management, life skills training, intensive case management services, non-medical transportation, and community access, and then room and board. So to provide a little bit more information about what that life skills training requirement entails, this requires that the facility is supporting individuals to maintain and develop skills for independent living through regular, structured, individual, and group engagement opportunities. And it also includes therapeutic and habilitative activities to facilitate the development of life skills, promote independent living, and support the pursuit of the individual's interests and goals. Intensive case management is also one of the services being provided, and there are specific standards written into the chapter. A general overview of those include facilitating collaboration of the individual's care team and personal supports, identifying health-related social needs and facilitating access to resources needed to address those social needs, those health-related social needs, and discharge planning. So ensuring that a comprehensive plan is in place to support individuals, given that the goal of this setting is to help individuals stabilize and then transition into a more independent setting. For documentation, following along with that structure that Mariana had outlined for each part of this chapter, the documentation section includes requirements for the pre-admission assessment, which includes screening requirements from Chapter 2, but then builds into the initial service plan, which must be completed within 24 hours of admission, a comprehensive assessment completed within 10 days of admission, and a comprehensive service plan that is completed within 14 days of completing the comprehensive assessment. So these timelines are a little bit longer, given that this residential setting is more of a long-term setting, and individuals are transitioning from significantly different levels of care. And so ensuring that there is time to develop comprehensive service plans that align with kind of their needs as they're adjusting to the new setting, but also ensuring that from day one, there's an initial service plan in place that's addressing things like the needs that they have in terms of support with ADLs, medication management, et cetera. I will pass it back to Marianne, I believe, to dive into clinically managed services.
Okay, thank you for that, Erica. And for those of you who are curious, the Hulk did win. So the battle is over. We're good to go there. So clinically managed services are defined in Chapter 1, and this particular category are services that are directed by clinical personnel, which may include, but are not required to be, medical personnel. These services involve on-site behavioral health support to address problems related to emotional, behavioral, or cognitive concerns, readiness to change, relapse, or the recovery environment. Next slide, please. All right, so the first one we're going to look at is Part 8.6, and this is ASAM 3.1 type services. Next slide, please. So you'll see now that we've gone through the structure pretty well in depth, I will hit fairly high level with the actual levels of care for the sake of time, and especially for a lot of these levels of care, they're already existing and we did not change too terribly much. So I'll highlight more or less the things that are a little bit different. So service delivery and setting for an ASAM 3.1 type service, not a ton of changes here, with the exception of obviously adding in a mental health option and criteria, which you'll see in the rule volume. For personnel at an ASAM 3.1 type level, we have kept the individual to personnel minimum ratio of 20 to 1 at all times, including weekends and overnights. And then if the program is providing substance use disorder or co-occurring services, as we mentioned before, they can utilize certified addiction technicians as treatment personnel. They can also utilize counselors in training and or interns for this. And so we have continued the existing ratios that are in our rule volume right now of a maximum of 25% of the total personnel as CATs or counselors in training and or interns. And then the service provisions that carried over into 3.1 are, again, current standard, minimum of 5 hours per week. Next slide. Thank you. So documentation and timeliness, I'll go through this first one for ASAM 3.1, and then in the future ones, most likely just touch on the progress to date notes, because that's where the changes are going to be visible at the current moment. So the required within 24 hours of admission, we have demographic, intake and consent paperwork, screenings, and the initial assessment as defined in Chapter 2, as well as the initial service plan addressing the individual's immediate needs. No later than 10 calendar days after admission, the comprehensive assessment is put into place. And the standard is written in that if the comprehensive assessment indicates further evaluation, medication, or behavioral health care is needed, that the agency must ensure that this need is met and document how that need was met. And then as soon as possible, but no later than 3 calendar days after the comprehensive assessment, we have the comprehensive service plan to be put into place. For this particular level of care, ASAM 3.1, there is a minimum of weekly progress to date notes. And again, this is carried over from current state, how we have this written in. So as mentioned before, with the way that we restructured this to meet that stakeholder feedback, we now have this documentation and timeliness lives in each particular level of care. So there will be room to potentially tailor the the particular requirements that we have here, if there is a level of care where it makes more sense to have the comprehensive assessment done sooner rather than later. It gives us a lot more flexibility. So for now, we have carried over what was stakeholdered before because it matches current state, and are definitely open to feedback around that. Next slide, please. Okay, level 3.2 withdrawal management is our part 8.7. Starting off with a little asterisk here, because we're going to take a little detour to talk briefly about current state versus future state clarification, so that we can make sure we're giving as much information as we possibly can. And I will take the next slide. Okay, so what we're wanting to get across here is our current state. We are completing this proposed rule update based entirely on the 3rd edition ASAM criteria, and this is the published edition from 2013. What this will look like is the rules that we come up with in this process are anticipated to be effective as of January 1st of 2024, and they will remain in effect until new rules are promulgated by the Behavioral Health Administration. The current services that we're putting, the current rules that we're putting forward and the services that are in place right now across the state are not immediately impacted by the release of the 4th edition ASAM criteria. This is definitely something that has been of significant concern in some of the stakeholder events, a lot of concerns about what that 4th edition release might do and when that impact might be felt. So future state. The ASAM 4th edition is expected to release in fall of 2023. These standards are not expected of Colorado providers until the 4th edition the Behavioral Health Administration promulgates rules that are based on the ASAM 4th edition. That will require a full stakeholder process with the Behavioral Health Administration, HCPF, stakeholders. That's going to be a whole separate process. And I feel solid in saying that today because we've had the ability to connect with HCPF and have some of these discussions. So we can confidently say that we are in alignment with HCPF at this point, that we are not anticipating any immediate impacts to that, and funding 3.2 services in particular has been of significant concern. That is a future state ASAM 4th edition rule process. That is not something that is a concern with this particular rule volume, but we will address it together as a state. Next slide, please. Any questions on that one? I feel like that, and I see, let's see here. Any questions on that in particular, I guess, because that we'd like to get those out so we don't have concerns about where that's going. Tom, you probably could say it better than I did. Go for it.
I could not say it better than you did, Mary Anna, but I do have the advantage of having met with HCPF one more time than you did, and we spoke about this just prior to this meeting, in fact. And so we got a little bit of additional information about how HCPF will handle this with the Centers for Medicare and Medicaid, specifically when the new ASAM volume comes out, that HCPF has the obligation to work with the BHA to develop a plan on how it will ensure conformity with the new standard, and then developing a funding rate or scheme to go along with a new standard. And then we will work jointly on that plan, submit that to CMS, and then go back and forth perhaps and get a final approved plan from CMS. It is only after that, and only after the BHA has promulgated new rules to support HCPF's funding scheme and also ensure quality for that particular level of the ASAM standard, that any of that will change. In the meantime, the current volume remains in effect. The funding flows for that, our licensing standards continue to exist in the way that we are stakeholdering and promulgating them now. So, Mariana, that's just in addition to your already excellent overview.
That was generous. Thank you, Tom. Yeah, and I see there's some questions coming up in the chat. I think, Rob, to the questions that are going into some specifics, I don't think we're going to be able to answer those today. I think going back to what Tom said, that is future state discussion. So we'll definitely take the note of what that is going to look like. But absolutely, we're wanting this to be a really robust stakeholder process and that nobody gets left behind. If we can go to the next slide, I actually have we are working right now to get a presentation together, a brief little blip at the provider convening that we're trying to sneak into, that will have the BHA as well as HCPF that can speak a little bit more to this particular concern. So I'm going to go ahead and pop into the chat the registration for that particular event. Again, we don't have a significant amount of time, so it won't be focused only on that, but we are hoping to at least get a 10-minute window where we can address some of these concerns. Next slide, please.
So just before we move on, I wanted to let you all know. So we're trying to answer, because of the time today, we're trying to answer questions in the chat in a written response when possible. So we have been doing that here. I think one that you might be able to clarify real quickly, Mariana, was a question about the counselors in training. So the question around what are they in training to be, could you just give a quick explanation of what we mean when we say counselors in training, and we'll work on written responses for the rest.
Yes, just one second. I actually always have to pull up the counselor in training definition because it is, the distinction between like counselor in training versus intern. I always want to double check myself before I give that information. So what I might want to do on that one, just for the sake of time, is if I can come back to that so I can just double check before I say something out of line, that would be fantastic.
Sure, we'll continue getting things responded to in the chat, and we'll keep pressing on. Thanks,
Beautiful. Mariana. Thank you. Okay, so current state level 2, level 3.2, I keep skipping the 3, not sure what that's about. Withdrawal management highlights. Again, looking at current state, we didn't put in a ton of standards that are significantly different from the current expectations. There is an additional requirement that the individual must meet diagnostic criteria for substance withdrawal disorder as indicated in the DSM-5 TR. Certainly open to feedback around that as well. Personnel. At least 2 personnel per shift, and at least one of those personnel must be what we identified as treatment personnel in the discussion before. The ratio is continued current state, individual to personnel must not exceed 10:1. And we kept the percentages and the ratios for staffing around the 3.2 as they are current state. And again, still open to that discussion as well. We did not have a lot of feedback around that. A lot of the feedback that we had on ratios was specific to the candidate issue we had a few months back, but we've not heard a lot around this one. So if you do have thoughts that this is difficult to staff or there's problems, now's the time to please let us know. Personnel requirements are specific to each physical location providing this service. At least 50% of personnel must be those identified treatment personnel. No more than 50% of personnel are uncertified or without a plan for addiction certification. And with how we have this structured now, that group living worker will fit into that category. Counselors in training and interns that are providing services require co-signature. And again, this is something in current rule. Full-time personnel must achieve at least a CAT within 18 months of employment and to be able to demonstrate a plan for that completion. Next slide, please. So medication-assisted treatment for withdrawal management. This has been stakeholder before, so hopefully this looks familiar to most of you or some of you. So the facility is required to continue individuals on their existing medication-assisted treatment regimen and will only remove individuals from medications for opioid use disorder if it's medically appropriate or the individual requests it. They are required to inform individuals about medication-assisted treatment services and, got a little asterisk here, provide them directly with the individual's consent. So this is one where we're definitely looking for some feedback around this particular requirement. We've heard some positive feedback around that requirement of providing those MAT services directly. but we expected to have a little bit more feedback. And so we want to make sure that people are seeing that, because that is a little bit different. And the concern was we wanted to make sure that this is something that people were seeing in the rules. And if it was going to have a significant impact, positive or negative, on an agency, that we have the opportunity to look at that proactively before that standard is put in place. So please take a look at that particular standard within this section and give us some feedback in the form or email would be fantastic. The program is required to obtain a controlled substance services license if they intend to utilize stock controlled medications. Again, not different from current state. We did write in some clarification that the controlled substance license is not required if the medication assisted treatment services are provided through prescription writing only. Next slide, please. Documentation and timeliness for 3.2 withdrawal management. Within 3 hours of arrival, screening and triage, withdrawal management focused service plan, intake documentation, consents, personal inventory verified by 2 personnel, and documentation of vitals in real time. And this is meant to target, really within that first 3 hours, making sure that that individual is able to safely receive services there. And if not, let's get them to where they need to be, but also corrects an issue that we have in our current regulation around it's entirely possible that an individual could be in withdrawal management services for 72 hours and not necessarily have a withdrawal management focused service plan that really safely provides their services and their withdrawal. No more than 72 hours from the time of admission, we have a standard written in to update or amend that intake paperwork and consents if needed, to get the initial assessment completed, at least the initial assessment, update the service plan to reflect ongoing treatment needs, and referral and care coordination activities to support ongoing treatment. So really looking at that 3.2 withdrawal management level as an opportunity to possibly enter or resume engagement in treatment services when needed for an individual. Next slide, please. And then continuing with documentation and timeliness, the vital sign requirement has not changed from what it is current state, with the exception of now it is noted to be documented in real time. And real time is one of our defined new terms in Chapter 1. It is at least every 2 hours until vitals remain at baseline for at least 4 hours, and then at least every 8 hours thereafter until discharge. We're receiving a lot of feedback around this currently and concerns of how this is managed. So certainly still open to feedback around that. And then documentation per shift to include all monitoring activities. Next slide, please. ASAM 3.3 is part 8.8. Next slide. So not a lot of significant changes from current expectations. We did write in that this is not applicable to children under the age of 18 in alignment with current ASAM standards. And then keeping the standards that we have around personnel, certified addiction technicians, and counselor in training or interns are not able to be more than 25% of the total personnel. Minimum of 9 hours of planned treatment services per week. And this definitely emphasizes that it can be delivered in a manner and timeline that is meant to match the individual's assessed need that may be deliberately repetitive. Next slide, please. So here's where I'm going to go ahead and start breezing past the first few bullets and really focus on the progress note frequency, because that's where the difference lies in these residential chapters based off of current state. So this level of care requires a minimum of daily progress notes. Next slide. And we go back to Erica for level 2 mental health transitioning living homes.
Thanks, Mariana. So our level 2 mental health transitional living homes are a clinically managed service. So these homes have been set up, or these rules have been written in collaboration with OCFMH, who's worked really closely also with HCPF in determining these 2 levels and how they'll fit within the continuum. In terms of our rules, though, they are situated at a clinically managed level of care because they're providing direct clinical services. So I'll take the next slide, please. So the section that addresses level 2 homes is really brief. These homes are complying with the rules for level 1. So all of those general requirements in 8.1 to 8.4, then those level 1 requirements in 8.5, and then as a clinically managed level of care, level 2 mental health transitional living homes are providing clinical services to individuals residing in the home. So the way that that has been defined is that at least 600 minutes or 10 hours of planned treatment services are provided to each individual on a weekly basis. And how that is done, whether that's group, individual, things like that, can be dependent on the individual's needs in their service plan. But it must meet that 10 hours. And that is all that we have for that service type. So I'll hand it back to Mariana.
Thank you, Erica. And I see that it looks like Victoria was doing exactly what I was doing and tracking down the definition for counselor in training. And part of the reason I always refresh my memory on that is to see, what that could be. And so I believe the majority of the counselors in training that I have come across are those individuals who are seeking an addiction certification in the process of their CAT. And so that is where I would say that is one example of one of what the counselor in training might be. So, and Jenny, going back to your question, yes, CATs have their own official definition as well as CASs. So this counselor in training is meant to capture that pre-counselor certified addiction technician period of time. I feel like that's a good solid way to look at it. ASAM 3.5 type services are part 8.10. Next slide, please. So again, not a significant amount of change with current state, except for adding in a mental health option and criteria. This level of care requires at least 2 personnel on site when 1 or more individuals are present. The personnel ratio has not changed. It cannot exceed 20:1 at all times. Be less than 20:1 at all times. I need to work on that. If the provider is providing a substance use disorder co-occurring services, they may utilize, again, certified addiction technicians or counselors in training or interns, no more than 25% of total personnel. And then the service provisions match current state, a minimum of 10 hours of planned treatment services per week. Next slide, please. With this, we're going to skip right down to the progress notes because this is where it changes. In recognition of current state and some disruption that could be made to some of the longer term therapeutic communities that are typically a 9-month stay, 9 months or more. We have a distinction here of if the anticipated length of stay is 3 months or less, daily progress notes would be the minimum. And if the anticipated length of stay is more than 3 months, a weekly progress note would be an appropriate minimum standard. Next slide, please. So moving into medically monitored services as defined in Chapter 1, these are services that are provided by an interdisciplinary team of personnel. We'll have nurses, behavioral health professionals, other healthcare professionals under the direction of a licensed physician. Medical monitoring is provided through a mix of direct individual contact, review of records, team meetings, 24-hour coverage by a physician, and quality assurance programs. Next slide. So ASAM 3.7 type services are part 8.11. Next slide. And again, not significantly different from current expectations. We did add in the mental health option and criteria. This level of care has a minimum of 2 personnel on site when 1 or more individuals are present. And personnel ratio must not exceed 20:1 at all times. This is an interdisciplinary team that is overseen by a physician, and the nurse is responsible for monitoring progress and medication administration. The service provisions, again, carried over from current state, a minimum of 20 hours of planned treatment services per week. The registered nurse will complete an alcohol or other drug-focused assessment at the time of admission. We've added if applicable here because, again, adding in the mental health option, that might not be necessarily applicable to all of our treatment types at this point. And then following current state, authorized practitioner completes a physical examination as soon as clinically feasible, no more than 24 hours after admission. And then we've added in a thereafter as necessary subpoint. Next slide, please. Again, skipping most of the stuff here because it's all the same until we get to the daily progress notes that are required for this level of care. All right, so then hang in there. 3.7 withdrawal management is part 8.12. Next slide, please. Not significantly different from current expectations. We did add into this level of care, again, the diagnostic criteria for substance withdrawal disorder as indicated in DSM-5-TR. So absolutely curious your thoughts and feedback on that. Personnel for this level of care, as in current state, at least 2 personnel per shift when 1 or more individuals are present. And again, with this being more of a medical service, the personnel must be present at a rate that meets the needs of the individual served in that medical type service. This type of program must employ at a minimum a medical director who's responsible for oversight of the agency operations, a registered nurse with at least 1 year of withdrawal management experience, and treatment personnel, as we've already defined, and again, matches current state. Next slide. So this one we've already covered. This particular level of care has the same expectations for medication-assisted treatment for withdrawal management. With the exception that with 3.7 withdrawal management, they will have that controlled substance services license because they utilize controlled medications for withdrawal management purposes. Next slide, please. So, and the same expectation, we have this written in as it is for 3.2 withdrawal management. And again, now that we have it in different sections, if this does not fit this level of care, this can certainly be tailored to meet 3.7 withdrawal management, but the same expectations within 3 hours of arrival, no more than 72 hours from the time of admission, updating the paperwork and initial assessment and service plan. Still viewing this as a great opportunity to enter or resume engagement in treatment services. And this one will look a little bit different because of the utilization of controlled substances for withdrawal purposes. The individual record will contain the informed consent to receive medical withdrawal management services, again, current state. Next slide. So there are a couple standards that were written in here as really meant to provide clarification. There is a standard that makes it clear that programs utilizing stock controlled substances need to have the controlled substance license. There is a standard that speaks to, I always pronounce this incorrectly, buprenorphine, for medications for opioid use disorder services are allowed to do that without opioid treatment program status, but other controlled substances for MOUD services do require the OTP type license. And qualified practitioners may request an exception to allow a 3-day supply of medications to individuals experiencing acute opioid withdrawal symptoms. Next slide, thank you. And then, so this one does have the same, we put the same minimum standard of vital sign requirements and real-time documentation in this 3.7 withdrawal management to have some standardization there. With some of the stakeholder feedback that we received, there is an exception that's written in that if the medical personnel determine that vital signs should be taken at a frequency that is less than the minimum standard that is noted, that the rationale must be documented, and that is within their scope of practice to make that determination. We're just asking for the documentation explaining why. Next slide. Okay, we are at a question section, so I will hand it back to Victoria to lead us through that.
Thanks. I think we have been able to tackle a number of these in the chat. There was one a little while ago from Rob about length of stay. I wondered if this is one you would know, Mariana. We can take it offline and do more research if needed. But Rob asked, are we letting courts determine a level of care? I saw it said provider will determine length of stay, but should they be able to refer to residential without an assessment? So that's specifically talking about those court-ordered.
Gotcha.
treatment.
So thank you for the question, Rob. We cannot say that our providers are able to, we're not able to say that what the provider assessment says will ever trump or directly step over a court order. We're certainly not able to do that. What we're putting forward is a way to really make sure that the assessment that the provider completes they have the opportunity and the encouragement to address if there is a discrepancy between the length of stay and some clinical necessity, so that there is a discussion between the supervising entity and the provider to make sure that we're filling that individual's time with clinically relevant services. We are not able to say that the provider 100% determines that length of stay, but this is one step in the direction of making sure that the clinical needs of the individual are also at the forefront in that scenario when you have somebody who is assigned to a length of stay that is not necessarily clinically appropriate. So does that answer your question, Rob? I hope, and I can't see you on my screen. I might have to try to find you. Okay, I don't see you, but if that does not answer the question, please let me know. But that's what it's intended to be, is a way to make sure that the clinical assessment is also considered and relevant for their services.
I just want to also acknowledge Allison's question regarding our controlled substance license and prescribers. Wanted to let you know that we're phoning a friend behind the scenes, our state opioid treatment authority, to get our response for that question. So thank you for that. We are on it. I'm trying to see. Oh, just another note. There was a question about the slides. Just want to emphasize that our slide deck will be available on our webpage, as well as our recording of this town hall. So if you're not able to read everything or grab a screenshot or take a note, we will have all of these available for you following the presentation. I think we're all caught up in the chat. So I think we can keep moving. All right, and we will throw it over to Olivia, who will be talking about Chapter 9, our emergency and crisis services.
Thank you, Victoria. So who does this apply to? Providers that are serving individuals on emergency. Oh, that is not correct. I'm sorry. Our chapters got switched around. This is for providers serving individuals in crisis. All right, so starting off with our person-centered summary, emergency and crisis services are available when you have an urgent concern regarding your mental health, or if you are in need of immediate support. These services can be provided to anyone that is uninsured or unable to pay for services, as well as anyone that is not a Colorado resident or does not hold citizenship in the United States. These services include 24/7 support over the phone or the 988 line. If you ever need to talk with someone, and you may be connected to appropriate resources in your community if needed. 24/7 walk-in centers should you feel unsafe in your environment or in need of immediate professional help. 24/7 mobile crisis services, where a professional can intervene in a crisis situation wherever you are. And we have crisis stabilization units and acute treatment units. You'll probably notice that this is a little different. We have decided to keep current state with those, and I'll get into that later. But this is where you will receive a full assessment, medical or medication treatment, individual and or group counseling, and referrals. And lastly, we have our respite services, which may be provided in an inpatient or community-based setting, depending on your individual needs. Respite services are short-term services that are offered 24/7 that work around your schedule in order for you to maintain your daily routine. These services provide support around daily living activities, assistance with medical and physical health needs, life skills, environmental maintenance, relationship building, safety planning, and more. Next slide, please. Thank you. So skipping to our definition sections, we added the definition of 988, which means the National Suicide Prevention Lifeline, or the Lifeline. Clearance practice means the process of identifying specific health needs and conditions that may require specialty management and a higher level of care, such as a crisis stabilization unit, acute treatment unit, or inpatient psychiatric hospital. And accepting agencies may have varying requirements prior to accepting a referral. The definition of crisis assessment was added. This just means a standardized assessment form created by the BHA. Crisis professional, which means any individual who's receiving or has received crisis professional curriculum training approved by the BHA specific to crisis assessment, management, de-escalation, safety planning, and all relevant laws and provisions. And once the training is complete, this individual can lead a crisis response. And lastly, we have our paired mobile response definition, which means a mobile crisis response in which two personnel respond, one person on scene and the other person on scene or via telehealth. Both members of the paired response should be crisis professionals. Okay, moving into our emergency and crisis provisions. We did add endorsement language for all different levels of service within this chapter. And then brought this over from other slides, did want to provide some clarification. So each component within the behavioral health crisis response system as a whole, identified under section 2760-101 CSR or CRS, may be capable of serving. So before there was just some confusion if every type of agency needs to be able to do this, or if it's just the response system as a whole. So it is just as a whole, not every single place has to be able to serve all of these populations. So children and families, and if you're serving children and families, you have to have that endorsement. Adults and older adults, individuals with co-occurring conditions, including mental health conditions, substance use disorders, medical needs, IDD or physical disabilities, traumatic brain injuries and or neurocognitive disorder, as well as individuals demonstrating aggressive behavior, individuals who are uninsured or unable to pay for services, and individuals who may lack Colorado residency or legal immigration status. For our telephone crisis services, as mentioned in the definition, we did add some 988 language just to keep up with what's going on. And then telephone crisis services must provide screening and triage, psychosocial support, connection to appropriate resources, follow-up capability to callers as clinically appropriate, and access to a support line, also known as a warm line, provided by peer support professionals. Peer support professionals must have the ability to seamlessly transfer individuals to the crisis line when urgent clinical intervention is warranted, and services must be provided in a culturally responsive manner. Providers must also develop contingency policies and procedures for emergency management, including but not limited to individuals experiencing acute behavioral health emergencies and coordination with agencies that provide emergency service interventions. All right, moving right along to walk-in crisis services. So all walk-in crisis facilities must be 2765 designated, which is our chapter 15, as well as obtain a children and families endorsement. A walk-in crisis facility must have the capacity to screen and triage every individual who presents at the facility with any presenting problem, including acute and chronic substance use and or IDD, coordinate multiple simultaneous requests for services, work closely with community partners, family members, or caregivers, and work with local hospitals to develop accepted clearance practices to divert the individual in crisis from emergency departments for the purpose of verifying medical stability prior to residential or inpatient admission. The facility shall manage and prevent elopement of individuals on an emergency mental health hold using strategies in conformity with state and federal regulations. Individuals in crisis must be screened and triaged within 15 minutes of arrival, and crisis assessments must be completed in full on a BHA created form. To continue just services that must be included, we have brief intervention, stabilization, and de-escalation intended to maintain stability in the community whenever possible, to include such as activities as on-site interventions, care coordination, skill building, crisis prevention strategies, and lethal means restriction, peer support to reduce stigma and build connection, and identifying natural supports, as well as substance use services, which may include harm reduction interventions, including the administration of naloxone to reverse an overdose if needed. And walk-in facilities may offer withdrawal management services if they are endorsed to do so. And then lastly, they must be able to do a physical health screen if indicated. So just wanted to get a little more in depth regarding safety planning, referrals, and follow-up for walk-in crisis facilities. So they must develop crisis safety plans, which should include psychiatric advance directives in collaboration with the individual in crisis and their family members and/or other social supports unless clinically contraindicated. Our referrals, which walk-in facility staff are responsible for all referrals and warm handoffs to health and social services and supports, including that withdrawal management as needed. And appointments should be attempted to be scheduled within 7 business days of referral. And then for our follow-up services, they must be provided to every individual and must include follow-up by a member of the responding team to each individual and authorized caregiver and/or family members by phone or in person based on the clinical need and individual preference. And the first follow-up must be within 24 hours after services were provided. And follow-up communication may be conducted face-to-face via telehealth or via telephone only, based on the clinical needs and preferences of the individual. And then moving on to our personnel requirements for walk-in crisis center. These also apply to our CSU personnel requirements. So if the crisis stabilization unit. So if it seems short when I get to that, it's because these are also included. So a walk-in crisis services facility must employ sufficient staff to ensure that the provision of services meets the needs of the individual. And at a minimum, a facility must have 2 on-site staff at all times. A walk-in crisis services agency must always have a crisis professional on site who can lead the crisis intervention and assessment. Providers seeking crisis professional status must complete training required by the BHA, and the status will be tracked on a yearly basis. And lastly, a walk-in crisis services agency must have access to a licensee within 15 minutes via telehealth if one is not available on site. Just kidding, not the last one, a couple more. Walk-in crisis teams must include a staff member with specific training and expertise in serving children and their caregivers who experience crisis, as well as staff trained in responding to individuals with intellectual developmental disabilities, traumatic brain injury, severe mental illness, serious emotional disturbance, substance use disorders, co-occurring disorders, and other cognitive or neurodiverse needs who are in crisis. And walk-in crisis teams can develop contractual relationships with local providers with expertise working with the populations. These providers must be engaged during or immediately after initial face-to-face intervention as needed to support individuals in crisis who do not already have an existing relationship with a provider. And telehealth may be used to secure expertise for individuals served by the mobile crisis response team with IDD. Okay, so here's where we get into crisis stabilization unit services. As mentioned before, we are no longer combining crisis stabilization units and acute treatment units as one combined service. So CSUs will remain current state, which can be found in 5 CCR 502-1, section 21.400.4.d. So CSUs were previously required to be 2765 designated. This is optional now, but they must be in compliance with all of the residential and overnight standards in 2.26. And they have to ensure that individuals cannot be appropriately treated in a less restrictive setting. So like I just mentioned, the personnel requirements that I just listed for the walk-in crisis services also apply to crisis stabilization units, as well as access to an authorized practitioner upon admission, and at minimum, 1 on-site staff member qualified to administer medication. All crisis stabilization services shall meet Chapter 2 requirements, including requirements for screening, initial assessment, and comprehensive assessment, which is to be completed within 24 hours of admission, medical and medication treatment, peer support when clinically appropriate, discharge service and safety planning, care coordination, and referrals. And clients shall be assessed for continued appropriateness for treatment in the crisis setting at least every 3 days. And crisis stabilization services shall include at a minimum medication management and individual or group counseling. For our mobile crisis services and units, a mobile crisis unit must operate 24 hours, 7 days a week, 365 days a year, and providing community-based crisis intervention, screening, crisis assessment on the BHA created form. This is only if it's clinically indicated by the initial screening as described in Chapter 2, and then referrals to appropriate resources. All agencies that are providing mobile crisis services or responding to crisis calls shall meet the critical incident reporting procedures in accordance with Part 2.17. Safety plans, again, which are to include psychiatric advance directives, must be creative. Follow-up services must be provided within 24 hours from when services were provided. And mobile crisis response teams will provide brief intervention, stabilization, and de-escalation services intended to maintain stability in the community whenever possible. Just to clarify the dispatch information, we did add something that was not previously in rule. So wanted to clarify this first bullet that mobile crisis response teams must arrive to the community-based location where a crisis occurs within 2 hours of accepting a dispatch request for rural and frontier areas, and within 1 hour of accepting a dispatch request for urban areas, including dispatch from the statewide hotline or 988, either face-to-face or using telehealth operations. Mobile crisis response teams and the statewide hotline or 988 must use the standardized dispatch criteria available from the BHA, which is on our website. And if the statewide hotline or 988 requests a mobile response, a mobile crisis unit shall immediately accept the request, which means to affirm the request from the hotline and immediately dispatch the mobile crisis response team. And any rejected requests are subject to review from the BHA or their subsidiary. So hopefully that clears up some confusion about what not accepting a dispatch would look like. Okay, so personnel requirements. Most people will probably be very happy to hear that we have removed the 24/7 access to a peer support professional, excuse me. And then we have kept that mobile crisis teams must include a staff member with specific training and expertise in serving children, youth, and their caregivers who experience crisis, as well as staff trained in responding to individuals with IBD, traumatic brain injury, severe mental illness, serious emotional disturbance, substance use.
Wait, Berta, wait.
Oh. Traumatic brain injury, severe mental illness, serious emotional disturbance, substance use disorders, co-occurring disorders, and other cognitive or neurodiverse needs who are in crisis. They may develop contractual relationships with local providers with expertise working with different populations, and telehealth may be used to secure expertise for individuals served by the mobile crisis response team with IDD. Mobile crisis response teams must develop a training plan to ensure expertise in addressing specific population needs. And they may utilize emergency medical technician paramedics with a community paramedic endorsement and alignment with a community integrated healthcare service agency that is working with the mobile crisis response team. All right, almost through the crisis rules. So respite care, we have, we previously had residential, outpatient, and community-based, so we've now just cut that to residential and community-based respite services. These are intended to be a flexible intervention or set of services based on the presenting concerns of the individual. Residential respite services shall be provided in a properly licensed 24-hour facility by medical professionals within their scope of practice. And residential respite care services shall comply with all of the residential overnight requirements in that part 2.26. And then community-based respite care services should be provided in the individual's home, community, or other place of service as a temporary relief from stressful situations or environments. or to provide additional support in the individual's home environment. Again, these services are to provide temporary or short-term care by licensee, candidate, or personnel based on the level of care being provided, and is designed for an individual that has experienced a self-defined crisis. Respite is intended to be a flexible intervention or set of services based on the presenting concerns of the individual in crisis, and must have the capacity to provide supports necessary to alleviate conditions leading to the initial crisis and enhance the individual's sense of safety and agency in managing their crisis. So things like support around ADLs or activity of daily living, assistance with medical and physical health needs, life skills, environmental maintenance, relationship building, safety planning, and more. In order to be eligible for residential or community-based respite services, an individual that has experienced a behavioral health crisis must be referred by personnel within the behavioral health crisis response system, agree to residential or community-based services, not meet emergency procedure criteria as outlined in 2765-106, and care and treatment of persons with mental illness. They must present a minimal risk of significant withdrawal complications, cooperate with program guidelines, and be able and willing to participate with accommodations if needed in performing a service plan. Services shall be intended to improve or maintain the condition and functional level of the individual and prevent relapse or hospitalization while providing a safe and calming environment to address precipitating factors to the crisis. Services shall include assessment, structure, support, and care coordination. All right, so acute treatment unit services. Again, this remains current state coming from the CDPHE rules 6 CCR 1011-1, chapter 3. Acute treatment services must be 2765 designated, and the BHE shall ensure that individuals admitted for acute treatment services are age 18 years or older, in need of psychiatric care, and cannot be appropriately treated in a less restrictive setting. An individual may be admitted into a locked setting on a voluntary basis as long as the following requirements are met, and the individual signs a form that documents the following: that the individual is aware that the setting is locked, and that the individual has the ability to exit the setting with personal assistance and/or permission. ATUs must follow admission and discharge criteria and service planning requirements in Chapter 2, as well as assessment requirements in Chapter 2, including both the initial and comprehensive assessment. The individual shall be assessed for continued appropriateness every 3 days, or at least every 3 days. The BHE shall have policies that identify when an individual requires a physical health assessment, as well as ensure the individual's service plan is created within 24 hours after admission. And ATUs must also be in compliance with all of the building standards, common area, bedroom, seclusion room, and bathroom standards, as well as linen and laundry standards. And those can all be found in part 9.9.2. And for our personnel training requirements, the BHEs shall ensure acute treatment services meet personnel training requirements in accordance with part 2.14.3 of these rules, with the following additions. The administrator shall have training in assessment skills, nutrition, and identifying and dealing with difficult situations and behavior management, and be responsible for the overall direction and supervision of personnel. And the clinical director shall have training in assessment and identifying and treating individuals who display behaviors that are common to individuals with severe and persistent mental health disorders. All right. Still got 30 minutes, so Victoria, do you want to throw some questions out there?
Great. Thank you for that, Olivia. We have been furiously drafting some responses in the chat, and there were a couple I don't think I have a response typed to yet. The question regarding if a CSU, this was from Lori, if a CSU is not 2765 designated, how would they be able to manage a person on a holder certification? Does that mean they would have to refer out for coordinated care? So if the CSU does not have that qualification to provide those 2765 designated services, then yes, that would need to be coordinating with another provider. So thank you for that question. There was, I see Megan Lee, our crisis expert and special guest, responded to Elizabeth's question regarding that follow-up and if that could be any member of the team. It sounds like that may be unclear, so we could provide some additional clarification in the rule if that would be helpful. I also wanted to ask a clarifying question of Elizabeth Richards, just to make sure I caught that this question, or I remember which question this was regarding in context. The referred by personnel within the behavioral health crisis system, previously only mobile crisis or WIC that could do the referral. Were you speaking, was that about respite services or something else? I apologize.
That's okay. Yes, it was in regards to respite.
Thank you for that. So this one, I think I've been chatting with crisis expert. I think this one we're going to have to take back and do a little more digging to make sure we're really clear on that referral process. So thank you for bringing that up, Elizabeth. We will take that one back.
Great, thank you.
Just want to address that 24/7 peer support. That is a new change we are expecting to make based on some significant feedback that is just not a realistic standard for a lot of providers, especially those in rural areas. So we are currently open to feedback to what that looks like, recognizing that peer support professionals can provide invaluable services in a crisis response, and what does that access or staffing look like in terms of peer support professionals. So just wanted to give you that update. That is hot off the press. And I see Cindy said that she will offer some suggestions. Appreciate that. And I am, let's see, working on getting through the chat. So a couple more came in. Oh, the question from Jenny Wallace about the staffing guidance ratio requirements. And again, apologies that reading this out of context. Jenny, could you clarify what section you're referring to? Was that ATU?
Yeah, the ATU section, and I was looking at it earlier today, and I didn't see the 1:6 ratio, and in all the other ones they have personnel requirements. I wasn't seeing that in this version, and I was wondering if that was going to get added or if that's just not something you guys are going to speak to.
Thank you for that question. So just for a little bit of context, those were carried over directly from the health department, and the ATU does carry the requirement of having that 2765 designation. So there's a little bit of needing to refer there. In that 2765 designation is that ratio requirement and more staffing information. So that one we did not include there because it requires the designation and it speaks to it there. So that's where you can find some more information about the staffing requirements for ATUs.
Thank you. That makes total sense.
Yeah, no worries. Let's see, reading through the chats. Tom, I wonder if you could speak to, I see the questions regarding CSU and the ATU or community clinic comments. I wonder if you'd be able to help speak to that.
Elizabeth, I'm seeing that question, but I Do you feel comfortable coming off of mute and giving us some more detail about that?
Oh, yeah, absolutely. I just was thinking about the previous question about what if a CSU is not 2765 designated. What I understood was that in order to be a CSU, you have to be an ATU or a community clinic. So in order to be an ATU, I mean, you'd have to be 2765. It's kind of like a circular thing. So if you're an ATU, you have to be 2765 designated in order then to be considered a CSU. So I wasn't tracking along with the question about what is supposed to happen with the CSU if it's not designated. But in order to be designated, they have to be an ATU or a community clinic.
I think I have an idea about the issue here, and it goes back to when OBH created the CSU program type, and it had to be licensed with CDPHE as either a community clinic with emergency center, and then later at CDPHE just a community clinic, or licensed with CDPHE as an ATU, as those were two existing license types.
Right.
But with the passage of 1237? It's not coming to me right now. A House bill from several years ago, which created the behavioral health entity license type. ATUs and community clinics were subsumed into that license type. So now community clinics have to be licensed as a behavioral health entity from CDPHE. So does that get to the question?
Yes, I think so.
At least the first part of the question. The second part of the question about ATUs being designated, that really is an endorsement type under the BHE portion of the CDPHE license. So, and CDPHE has said that ATUs should be 2765 designated. Now, that particular part we've talked a lot about at the BHA, whether we collapse CSUs and ATUs, whether we continue to make them two different types of service under the BHE license. We've gone with the latter based on other stakeholder feedback, also coordination with HCPF in terms of funding conversations. And then, of course, saying that if you're going to be an ATU, that it requires 2765 designation. So I think that's kind of how the past state works into where we are now with the draft rules. And I hope that answers Elizabeth.
Yes, it sure does. Thank you.
Excellent. Thank you.
Thank you for that, Tom. I see the question from Cassie. If WICs will be required to prevent elopement to those on an M1, does that mean WICs will need to have the ability to follow restraint criteria and be locked facilities? How can you prevent elopement in a hands-off facility? So this is a great question. There is a statutory requirement for walk-in crisis or WICs to be 2765 designated. And in that, the agency has the opportunity to choose whatever interventions may be appropriate. If they want to use seclusion and restraint, that would be an option as long as that is done in accordance with our regulations, or lock their facility. Our rules do not prohibit that. So it's up to the agency how they would want to handle that particular situation, but those would be options provided they're done in accordance with our regulations. And again, there is that 2765 designation requirement for WICs. Cassie, yes.
Yes, I'd love to follow up. So for facilities who choose not to utilize seclusion and restraint, is there guidance on other methods to prevent elopement? because I would say like the facility that I'm connected to, we are a hands-off facility, so we are not utilizing seclusion or restraint. And if, if someone on an M1 is going to run out the door and elope, we're calling police, we're getting them help in that way, but we're not like running after them and tackling them. So I guess if an agency is not utilizing seclusion and restraint, or having a locked facility, what is the alternative to meet this requirement of preventing elopement?
Thank you for that question, Cassie. And I saw Tom engaged, so I will begin to answer. And then if Tom, if you want to add any additional information. So we don't explicitly, to answer your question, we don't explicitly speak to alternative interventions. We are really, if the agency is choosing to do that restraint and seclusion, obviously we're very interested in making sure that that is done in a way that is humane, that is empathetic to the individual, but we don't necessarily speak or regulate to other alternatives. Just to answer that part of the question, and I see Tom has come off mute as well.
Well, I'd like to say that I have a definitive answer to this. The reality is this is a area of deep concern for all of us, providers and BHA and advocates and people who receive services alike, because restraint and seclusion, while at some level could be argued is about protection, you're keeping a person from perhaps leaving the facility and attempting to hurt themselves or someone else. It can also be a very traumatic event for a person to be restrained or secluded for that matter. So we aren't requiring a facility to use restraint and seclusion, but if they do, then they need to do it in accordance with our regulations to that effect. I would say that any facility that does or doesn't, for that matter, needs to think how they will handle such situations, develop policies around that, and think about other alternatives besides restraint and seclusion that can serve the same purpose. We've had conversations about that very issue at the BHA, and we talk about it a lot. What are other alternatives exist? I'm not sure that any alternative is always better. For instance, fences. They can stop a person from running into a street. We talk about that in the context of an adolescent type facility. You in particular want to be cautious about restraining kids. So fences may stop a child from running into the street. It also presents a particular feel to a facility to put a fence around it. So I'm not suggesting that that is the correct answer. It may be an alternative in certain circumstances. It's going to get down to the specific facility, and in some cases, it's going to get down to the specific person receiving services. There are times when restraining one person is an appropriate intervention, and restraining another person is not, if you think about a trauma-informed approach by individual. So I know that's not a definitive answer. And I appreciate everyone's hard work thinking about those particular issues. Thank you.
I also see the follow-up question. We only use physical management on our ATU, not seclusion and restraint. Is this an acceptable alternative on the WIC, elopement of someone on a hold? Interested in Tom's thoughts, but I would think that that would be an alternative. We're not saying that seclusion and restraint are required, just that the facility is utilizing some strategy to prevent that elopement of individuals on holds. And I see Tom nodding, but would you agree?
Yeah, I don't have anything else other than that, Victoria. I think you stated it very well.
Thank you. Seeing that we've got about 14 minutes left and one more chapter to cover, albeit that is a quite short chapter, I think we continue on. And then if there are any other things in the chat we can revisit after we complete our presentation, we will do so. So we will throw this back to Olivia.
All right, thanks, Victoria. For chapter 10, we have, as Victoria said, our emergency and involuntary substance use disorder commitment services. This applies to providers that serve individuals placed on emergency and involuntary subcommitments. For a person-centered summary, we have substance use disorders are very complex and may result in doing things that can cause harm to yourself or others, resulting in your family members or providers becoming increasingly concerned about your safety or the safety of others. You may be placed on an emergency or court-ordered involuntary substance use disorder commitment if your substance use disorder is causing severe harm to yourself or others. An emergency commitment means that you must stay in an approved treatment facility for up to 5 days, and an involuntary commitment means you must attend treatment at whichever level of care is needed to keep you safe and move you toward treating your substance use disorder. So if you notice, we did change the title from alcohol and drug emergency and involuntary commitments to emergency and involuntary substance use disorder commitments, just to be more clear and not confuse anything with 2765. And then we did add endorsement language for both the emergency and involuntary commitment services. This is an optional add-on endorsement, and this will be treated as a population-specific endorsement to add on to any services you guys are providing. Just some further information on emergency versus involuntary commitments. Emergency commitments is when an individual is under the influence of or incapacitated by substances and it's clearly dangerous to the health and safety of themselves or others. And the individual is taken into protective custody in an approved treatment facility not to exceed 5 days. And then involuntary is when an individual that has a substance use disorder and has threatened or attempted to inflict or has already inflicted physical harm on themselves or others, or is incapacitated by substances and unless committed is likely to inflict physical harm on themselves or others, is committed to involuntary treatment. We did that, the definition of pass, which means written permission by a residential treatment facility for an individual to leave campus grounds. And then we did add discharge summary requirements to the emergency subcommitment services, as it was currently only required for the involuntary subcommitments. And then we did receive feedback that we needed to add clarification that the BHA may delegate physical custody of individuals involuntarily committed to treatment pursuant to section 2781.112.5 CRS. And then we updated the personnel requirements just to match the rest of the substance use chapters. So primary counselors for individuals on involuntary commitment means the following behavioral health professionals trained in the substance use disorder identification and treatment and acting within their scope of practice, which can include an authorized practitioner, licensee, certified addiction specialist or CAS, or candidate personnel. Short chapter, that's all I've got.
All right, we've made it through our presentation. We've got about 10 minutes left. If there are any questions, I think I've kept up with the chat. I will double check that. And if there are any questions that I'm missing, please feel free to come. Oh, I see Elizabeth has taken me up on that. What do you got?
Yes, could you just clarify again when these rules go into effect?
Absolutely. So the proposed effective date for these rules will be January 1st of 2024. One thing I do want to mention is for, the these chapters are applicable to behavioral health entities or BHEs. A lot of those BHEs will be transitioning over to a BHE license from either a current substance use license or a current BHE license with the health department. One thing I'd just like to clarify, because I think this can be a little unclear and can cause a lot of anxiety. The expectation is not that on January 1st, agencies will immediately apply for their BHE license with the BHA. There will be a transition year that once the existing licenses are up for renewal, then the agency would be applying for a BHE license under the BHA and would then be subject to these regulations. So they go into effect. They are published January 1st of 2024 and will be applicable to agencies on a rolling basis as their existing license comes up for renewal, or if it's a new facility, of course, whenever they are applying for that initial license will be when they are falling under these rules. Did that help, Elizabeth?
Yes, thank you.
Absolutely. Oh, and I see Mariana took the opportunity to advertise our quality and standards newsletter again. Please feel free to sign up for that if you want the latest. Oh, and I also want to, there was one other question from earlier regarding the controlled substance license and the practitioners. Tom did answer that in the chat, but just to draw everyone's attention to it, since we had a lot of chat activity today. The previous question about alternative providers prescribing MAT, we are planning to alter our rule to allow for qualified practitioners. My understanding is that will be in a future rule update. We will include that clarification. CSL rules are not part of this particular rule update timeline. We are anticipating additional federal guidance in July of this year. And so we want to make sure that we are taking that into consideration when we are updating our controlled substance licensing rules. So we will be updating those, including that qualified practitioner piece. And I see Olivia's got some sneak peek proposed rule language around qualified practitioner that she has dropped in the chat. But once we have that timeline, we will let you know, but that is an update that we are anticipating to make. Did that catch everything you were saying, Tom?
That's fantastic. That's so much more helpful than what I wrote. This is not my area of expertise, but I was chatting with Ryan Mueller, who instantly made himself available to try to teach me everything that you just said.
That's great. Appreciate that we have those experts on call, and we didn't anticipate a CSL question today, but we got the expert behind the scenes and we got that answer. So go team.
I do have a question for those of us who are already a BHE, or we already have a BHE license, but we're wanting to add a detox to our continuum. And we want to do it sooner rather than later. I'm really confused about how to go about doing this, because right now our BHE license is with CDPHE and will be until next June 30th. So it expires June 30th of this year. And so I'm just trying to get some guidance on who do I talk to about that licensing process?
Can I take that one, Victoria? Yeah. Hello, Lisa. That is a great question. The best thing to do, that will still be managed by your currently assigned licensing manager within the Behavioral Health Administration. And sorry, I'm getting a little bit of feedback. I might mute your line real quick. And then just if you have a follow-up, unmute. Yeah, so that authority still remains with the Behavioral Health Administration. So if you're ready to start a withdrawal management program, absolutely reach out to your licensing manager. That would be a modification application to add that new service or that new location. And they'll help you through that process right away.
And one other complicated question, if we're also wanting to add a walk-in clinic as an endorsement. Because that one, yeah, that one, I don't know at all.
Like just to clarify, like a walk-in crisis clinic?
Yes.
So
Understood.
that would currently fit, I'll jump in, that would currently fit under your CDPHE BHE license. And so that piece, you'll want to reach out to CDPHE, given that they currently hold your BHE license, and they can help you in adding that sub-endorsement. And then when it moves over to us, that will all be one license with all of these different pieces.
Okay.
I think Lisa's question really highlights one of the great things that we are anticipating in making the system easier for providers. So per this question, we have certain regulatory requirements for substance use services such as withdrawal management, and then a separate agency even for different services. So one of the things we're really excited about with this BHE license coming to the BHA is future state, Lisa, this will all be under one singular license with one agency, and we anticipate that will be much more streamlined and less burden. So just wanted to highlight that question really gets to one of the reasons that we are doing this rule update. I think we have 2 minutes left. If anyone has any additional questions, we could maybe take one more. I will begin my wrap-up spiel, and if anything comes up, we can address it. So thank you all so much for joining us this afternoon on that 2-hour journey through chapters 8 through 10. We have 2 more weeks of additional stakeholder events. All of our chapters are available on our webpage if you want to review them in detail. We have a number of rules office hours coming up if you just want to bring any and every question or piece of feedback. We have our town hall for chapters 11 through 14, and then our chapter 15, which is the 2765 designation coming up. We have in-person events in Grand Junction and in Pueblo. We had our event in Durango earlier this week, which was lovely. Great to go. I went and I had a great time seeing the beautiful southern part of our state. And we have, I'm trying to think of other big ones coming up, and a couple of lived experience sessions, including our safety net lived experience session and our Spanish language lived experience session. So please check out our calendar. We will look forward to seeing you in other places, and we will have this uploaded onto our YouTube channel as soon as possible, and those slides available. So thank you all so much for being with us here today. And I see Cindy has, I think, put a recommendation in the chat, so we will be sure to grab that. Cindy saw a couple other recommendations earlier in the chat as well. So thank you for those, and we will record those and take those into consideration. Thank you for your time today, everyone.